Good afternoon. We welcome you to the webinar on. Good afternoon. We welcome you to a webinar from Concord Biotech, hosted by Dr. Deeksha Singh Tomar. Dr. Deeksha Singh Tomar is an MBBS from the GR Medical College in Gwalior. We welcome you to the She had a 2-year residency in anesthesiology from the GR Medical College in Govid from Concord Biotech. She has a 2-year training in critical care from Medanta Medicity in Gurgaon. Currently, she is the senior consultant critical care at the Narayana Super Specialty Hospital in Gurgaon. She has a 2-year residency in anesthesiology, and she has a 2-year training in critical care from Medanta Health Institute. Dr. Deeksha, welcome to the webinar, ma'am. We look forward to your presentation.
So, good afternoon, everyone. So this talk is going to be about the role of liposomal amphotericin for the management of COVID-associated pulmonary aspergillosis and mucormycosis. As we've all seen this disease, COVID, very closely in some way or the other, and we know that this has been a very catastrophic illness with high mortality and morbidity, especially if I talk about the first 2 waves. And this, like any other viral illness, has led to many secondary infections, especially in the patients who have got comorbidities, who have earlier illness, who have got compromised immune status, making them susceptible for secondary infections. Not only this, the indiscriminate use of drugs like many immunomodulatory drugs, steroids, the overuse of antibiotics, indiscriminate use of zinc has led to the predisposition of these patients to the secondary infections, both bacterial and fungal. So I'll be talking about the 2 most lethal fungal infections associated with this COVID disease, the COVID-associated pulmonary aspergillosis and mucormycosis. Now, as intensivists, we've always been facing these problems of invasive fungal infections in our ICU. Not only the immunocompromised patients, but even the immunocompetent patients who are admitted in ICU for a prolonged period of times, they are prone for getting the secondary invasive fungal infections. It is difficult really to diagnose fungal infections in ICU patients because the patients are of various subsets. They are a heterogeneity of population. So the host factors which are associated with these invasive fungal infections, they may be absent in the ICU patients. So it makes it difficult to diagnose the infections in the ICU. And it has got an attributable mortality and morbidity across the world. So the European Society for Research and Disease and the Mycology Study Group, both of them, they have given a consensus definition on the diagnosis of fungal infections. The first definition was given in 2002, but in recent years, they have revised the definition so as to give a specific definition for the patients who are admitted in the ICU, who are non-neutropenic and critically ill patients. So what they did is they divided the definition on the basis of 2 levels of probability. One is the confirmed diagnosis, the proven diagnosis, or the patients with proven invasive fungal disease, and the patients with probable fungal disease. The proven fungal disease, it applies to any host where they've got a detection of fungus from the non-sterile, the sterile sites from the body, the blood, these sites where the fungus are normally not found. And the second is the probable, where they incorporated the 3 things. One is the host factor, where the patient have got one of the risk factors to get these opportunistic infections. The second is the clinical features, which suggest that the patient has got fungal infection. And the third is the microbiological evidence, whether it is direct evidence like the culture or the histopathological examination of the sterile sites, or the indirect signs like the antigen detection or the PCR test. So the high risk groups which we see commonly in the ICUs are the patient who have got Candida colonization at the sites like urinary bladder colonization, the upper airway tract colonization, or the patients with the comorbidities like diabetes, kidney disease, patients who are on hemodialysis support, they are prone for such opportunistic infections. The patients where the gut immunity, the gut barrier is impaired, like any major surgeries or the pancreatitis. The patients where the skin barrier is impaired, like patients who have got central venous line catheters, dialysis catheters, urinary catheters, they all are prone for invasive fungal infections. Not only this, even the broad spectrum use of antibiotics in the ICUs have led to secondary infections, fungal infections, or the secondary bacterial infections also. Apart from this, the patients whose immunity is already compromised, like patients with the organ transplantation, whether it is lung transplant or liver transplant or the hematopoietic stem cell transplants, the drugs they receive, the disease itself makes them susceptible for such invasive fungal infections. And obviously the malignancy patients have got weakened immunity, so they are also prone for such infections. So the liposomal amphotericin B, it has been the standard of choice, the drugs which has been used in serious fungal infections over the period of time, despite the development of newer antifungal agents. So earlier, the first molecule which was developed was complex with the deoxycholate. So we call it amphotericin B deoxycholate. Then because its nephrotoxicity and infusion-related reactions were very high, so to overcome these side effects and to broaden the index of therapeutic index, they have developed over the period of times various lipid formulations, and one of them being the liposomal amphotericin B, which is being recently used everywhere. So a little about the history. It belongs to a polyene group of antifungal. Among many drugs in this group, one of them is the amphotericin B, which was discovered way back in 1960. And it is produced by bacterium Streptomyces nodosus, and which has been used for the treatment of many fungal infections. It's a fungicidal drug, and it covers almost all the spectrum of the fungal infections, whether it is Candida species or the Aspergillosis species, the zygomycotic species, Mycosis, all these the groups are susceptible to amphotericin B. So it has been the gold standard for the treatment of such infections. These are the various lipid formulations which have been developed. The earlier was lipid B colloidal dispersion, in which the amphotericin B was chelated or complexed with deoxycholate. The other formulations where it was complexed with lipid complexes, we call it amphotericin B lipid complex, and the recent one and the smallest molecule is the liposomal amphotericin B, where the amphotericin is incorporated into the liposomes, making it more safe and fewer side effects for the use. Now, the spectrum of action of various antifungal agents for the Candida species. Here, as we can see, the polyene group in the amphotericin B, all the Candida species are susceptible to amphotericin B. They demonstrate a good microbiological activity and a good clinical outcome. Where if we talk about the triazoles, Candida krusei, it is inherently resistant to fluconazole. Otherwise, all other Candida species, they are susceptible to triazoles, except the Candida glabrata, which may show some resistance over the time. Echinocandins, again, they've got a good coverage. They cover all the Candida species. But if we talk about Candida parapsilosis, you may find some resistance or the higher MIC values for echinocandins. 5-fluorocytosine, this drug has got a weaker antifungal activity, and it is never used as a sole agent for the fungal agents, but in fungal meningitis, it has been used along with the amphotericin B, though the resistance development is quite high with this antifungal also. Now about the moles, polyene amphotericin, it is a good drug and drug of choice for the Aspergillus fumigators. Though Aspergillus terreus, it is resistant to polyene group. Again, amphotericin B is good and a drug of choice for zygomycetes, the mucormycosis treatment. If we talk about trizoles, as the newer generations have developed, they have become more and more susceptible to these molds. Fluconazole is resistant, and itraconazole has coverage for Aspergillus fumigators and terriers. Voriconazole has better coverage, including the zygomycosis, and posaconazole, along with isavuconazole, they have got a good coverage and cover almost all of the molds. Echinokindins, the Aspergillus species, they are susceptible to echinokindins, and the 5-fluorocytosine, it is resistant, and these antifungal, they don't act against the Aspergillus or the mucormycosis species. Mechanism of action, they preferentially bind to sterols in the fungal cell membrane and of the susceptible fungi, resulting in change in the permeability of the membrane, and this allows leakage of the intracellular components leading to the cell death. So it is basically leads to the cell death of the fungus. So it has got a fungicidal action. The approved indications, it is approved for empirical therapy for presumed infections in febrile and neutropenic patients. It is the treatment of choice for cryptococcal meningitis in HIV-infected patients. Again, it is the treatment of choice for various fungal infections like Aspergillus, Candida, or Cryptomycosis, which are refractory to either amphotericin B, or in patients where the renal impairment or the unacceptable side effects, they preclude the use of amphotericin B. It has got a good anti-protozoal activity also, and it has been the drug of choice for the visceral leishmaniasis in both immunocompetent and immunocompromised patients. A little about pharmacokinetics. If we compare liposomal amphotericin B from amphotericin B deoxycholate, we see the molecular weight of the amphotericin B is around 10% as compared to 34% in amphotericin D. It is the smallest molecule with a small diameter of less than 0.08 micrometer. And there you can see there is different shapes or the configuration of lipids in various drugs of the amphotericin B complexes. If we talk about dose, the dose of the amphotericin B deoxycholate is just 0.5 to 1 milligram per kg. The dose above this has got serious side effects. And if we talk about liposomal amphotericin B, it can be used in the dose of 3 to 5 milligram per kg. It can go up to 10 milligram per kg in the serious and refractory cases. About the Cmax and area under curve, both of these, we see it is increased with the use of liposomal amphotericin B, whereas the volume of distribution and clearance decrease. So it has got a long residence time in the blood and better clinical activity. When we talk about nephrotoxicity, amphotericin B deoxycholate is highly nephrotoxic as compared to the other lipid formulations of the amphotericin, and the infusion-related toxicity is least with the liposomal amphotericin B, and this infusion toxicity is very high with amphotericin deoxycholate, and it's moderate kind of activity with lipid complex and the colloid dispersion molecule. So there is a comparative efficacy. The lipid formulations have got a higher, if not equal efficacy as compared to amphotericin deoxycholate. Nephrotoxicity is very high with amphotericin deoxycholate, and it is least with liposomal amphotericin. Infusion-related toxicity, again, it is high with amphotericin deoxycholate and least with liposomal amphotericin. And definitely the product cost is high with the liposomal amphotericin B. Now, aspergillosis, we've seen that it causes broad spectrum of disease in humans, ranging from simple allergic reactions to lethal invasive aspergillosis. So, in this study, and which can apply to general population also, that the most common invasive aspergillosis is limited to lungs. More than 50% the disease is limited to lungs, but in patients who have got very compromised immunity, the disease may disseminate to other organs, leading to disseminated aspergillosis, and then it may disseminate to cause endophthalmitis, endocarditis, and may involve sinuses and other organs also. Now, talking about COVID-associated invasive pulmonary aspergillosis, or CAPA, this is defined as invasive pulmonary aspergillosis in patients who are being treated for COVID infection or who have recovered recently from COVID infections and have got pulmonary aspergillosis. So in particular, the patients have symptoms that are compatible with COVID-19 and they have confirmed positive RT-PCR. The patients who develop respiratory insufficiency, who require intensive care, they should be considered at high risk for pulmonary aspergillosis, because the COVID infection, it impairs the integrity of the epithelial lining of the lungs, and so that the opportunistic infection, the aspergillus in the lungs, it gets the entry into the bloodstream and the other organs, leading to invasive infection. So here, this article was published in the Lancet, where this consensus group, they give definition for the research as well as clinical guidance. They said that viral pneumonia, it has got increased susceptibility to bacterial and fungal infections, including pulmonary aspergillosis. And it has been seen that many cases are associated with COVID as a superinfection. And not only this, the azole-resistant pulmonary aspergillosis has been documented during the COVID. So this group, they give definition again based on the clinical features, the microbiological evidence, that they divided the definition into three groups. One is the proven, the other is probable, and the third one is the possible. So what they said is, if a patient is positive for SARS-CoV-2 and a patient is admitted in ICU and has got severe acute respiratory distress syndrome, then if there is histopathological confirmation that patient has got tissue evidence of invasive growth based on the culture or the PCR detection, or patient has grown the fungus in the blood, that is confirmed and has got a proven pulmonary aspergillosis. But if the patients, they have don't have these direct evidences, they divided the patient into either proven or possible pulmonary aspergillosis. For what way did they, if they took the bowel sample and there they found the evidence of the aspergillus in the bowel sample, or they found the galactomannan values of a particular index in the bowel sample or the blood, or the combination of all these, along with the imaging which is suggestive of pulmonary aspergillosis, like pulmonary infiltrates or cavitatory lesions, or both, along with the clinical features which are suggestive of infection, then they group those patients into the possible pulmonary aspergillosis. And if they were not able to obtain the bowel samples, the non-bowel lavage samples, they've got the evidence of this pulmonary aspergillosis, then they called it probable pulmonary aspergillosis. So this is how they define the aspergillosis associated with COVID-19. Now the treatment, if the bug is sensitive to azole, the drug of choice is voriconazole. They give 2 to 6 milligram per kg per day, for 6 milligram per kg per day for 2 doses, followed by from day 2 to 4 milligram per kg per day BD till the patient get cured. The other drug is isavuconazole, where on day 1 and 2 they give 200 milligram thrice a day for 2 days, followed by 200 milligram 1 day from day 3 onwards. Now, where the disease is resistant to azole, the second line drug is Liposomal Lymphoterrorism, where they use the dose 3 milligram per kg per day. For the cases who are resistant to azoles and they've got suspected disease, voriconazole plus echinocandins or isavuconazole plus echinocandins were used. But for the suspected or proven aspergillosis, the drug of choice is liposomal amphotericin 3 mg per kg per day. The second lethal fungal infection, though it is rare, but we have seen many cases in the COVID, is mucormycosis. The risk factors, again, we know the patients who are already immunocompromised in the COVID, the patients who have got diabetics or who have used prolonged steroid, or those who are on humidified oxygen, which may be contaminated with the fungus, they all may predispose the patient for mucormycosis. So we'll have to watch for the signs. The patients, they develop either the facial pain or the headache or the nasal sinus congestion. There could be black lesion in the hard palate, over the nose. There could be pain in the eyes, retroorbital pain, loss of vision, any signs which are suggestive of ocular or the sinus involvement. Along with the risk factors, we may suspect mucormycosis. There should be high index of suspicion, because if the diagnosis is delayed, the patient may even lose the life. So diabetics should be extra cautious. Their sugars must be under the controls, and we should avoid rampant and injudicious use of steroids just for saving lives in COVID. So again, we talk about mucormycosis. It's a life-threatening invasive fungal disease, belongs to Mucorales group. It leads to many clinical manifestations, from local to disseminated infections. The pulmonary or disseminated infections are found in patients with immunosuppressed status like malignancies, transplant patients, diabetic patients, or even the patients who have got trauma with the facial trauma. Treatment, despite treatment, mortality remains very high, around 40 to 70%. It depends on the organ involvement. Liposomal amphotericin B remains the first drug of choice in the mucormycosis, and treatment should be started as soon as possible. So there should be high index of suspicion for mucormycosis. If you've got suspicion of mucormycosis, you should get radiological examination done for such patients so as to diagnose the extent of the disease. And if the patient has risk factors, diabetes, hematological malignancies, or solid organ transplant, this makes patient more susceptible for mucormycosis. It's a diagnostic emergency as well as therapeutic emergency. So serum PCR kits are available to early diagnose the disease. If those are not available, you should obtain the sample from the infection site and send for PCR or the histopathological examination or the culture, whichever evidence we get, and then it should be treated. The ideal or the treatment modality should be the surgery first. If the patient is not operable, then only we give salvage therapy with the antifungals. Otherwise, surgery along with the antifungal should be given to such patients. The antifungal of choice is again liposomal amphotericin B. The dose is 5 to 10 milligram per kg, depending upon the severity of the disease. And if liposomal amphotericin is not being tolerated by the patients, the second drug of choice is isavuconazole. So guideline recommendations. These were recommendations for treatment by European Conference for Infections in Leukemia 2017 and by the Medical Mycology Society 2019, and they said that the dose is 5 milligram per kg as per the European Society for Infections of Leukemia, and as per the Mycological Society, the dose is 5 to 10 milligram per kg, and for CNS involvement, the dose goes up to 10 milligram per kg. So the take-home points: invasive fungal infections are important all over the world. The liposomal amphotericin B is as effective as conventional amphotericin B with fewer side effects and fewer nephrotoxicity. It is associated with fewer breakthrough fungal infections and less toxicity. Thank you.
Thank you, Doctor.
Yeah, thank you.
We were checking for comments and things like that. I think we're just trying to look for what comments are available.
Yeah, sure.
Just give me a moment. Great, Doctor. Thank you so much.